about Lyme disease. What is the problem that we're seeing in the world about Lyme disease everywhere in every country? The treatments, the testing, the symptoms. What is that you see?
Yeah, Lyme disease is a tragedy in the world. It's climate change. We have more and more ticks around the world. We have more exposure. People are going more outside. They got bitten from ticks without knowing that ticks can be dangerous with Lyme disease and co-infections. So they don't know, simply don't know. There's no prevention. They don't care about, they don't keep the ticks, so you could test the tick after tick bite. So they don't simply know. The next problem is if they got sick after tick bite, just let me say 20% recognize a tick bite, you don't feel it, you don't see it. So they got sick without knowing. Around 30-40% got the pulsar rash, 10% a summer flu without knowing there's a tick bite or a pulsar rash, 30% don't remember anything. So it's really complicated also for patients, and the same thing happened with the diagnostic tests. The diagnostic tests are very limited. The ELISA is a catastrophe. It has sensitivity, so let's better say false negative rate is around 70%, so 70 from 100 patients get misdiagnosed, false negative results. If you could be happy if you have a positive ELISA. The Borrelia
so usually
ELISA,
it's always negative.
Usually, not always, but just in 30% positivity. But the next challenge is the guidelines from IDSA. They say, okay, everybody who has Lyme disease needs to have antibodies. On the other side, these antibodies were not developed for diagnosing Lyme disease, because Lyme disease is a clinical diagnosis. It depends on your symptoms, what you're suffering on, the history on your symptoms, how it happens. Needs a good clinician behind that. That's the next challenge for all of us. We don't have enough knowledge among the clinicians. The guidelines from the societies, neurologists or rheumatologists, they block away the acceptance of chronic Lyme disease. They say chronic Lyme disease doesn't exist. Doctors, you don't need to care whatever the patient is telling you. So it's not existent, it's a syndrome, they name it, the guidelines from the neurologists as an example, or rheumatologists or dermatologists. They say chronic Lyme simply doesn't exist. It's a post-treatment Lyme disease, so you get a little treatment, 2 weeks doxycycline, simply too short for some patients, the dosage is not correct. So this is a really catastrophe coming to that, and in the final end, the patient is suffering. The doctors tell them you don't have Lyme disease because your ELISA is negative. The Western blot also very bad test, so we have just 60%, 60 from 100 positive, so 40 from 100 false negative. They have Lyme disease, but Western blot is negative. So that all doesn't make really sense in the field of Lyme disease. But Lyme disease is a clinical diagnosis, still to say, and it's really complicated for clinicians to understand it, because they all believe in the guidelines and they don't believe what the patient's telling them.
Why are we having the antibody testing?
Yeah, because this model came from HIV infections, where we have HIV ELISA and HIV Western blots, and this is a completely different antigen. What you said, Borrelia is a completely different antigen with a variability you cannot compare with HIV, which is easy antigen surface, and the tests are not detecting all of these antigens from Borrelia, but for HIV it's really great, 99%.
Yes.
Also the Western blots.
So we need to change those tests? Or do you have new tests?
We need to improve the antigenity in the test system to detect these antibodies. And what we have now in the laboratory is a TICPLEX name. It's a basic test, but this test, the test which has a broader breakthrough for all of us. It can detect the persister, the round bodies, the intracellular forms, because we saw in scientific projects with the European Union, with Professor Gilbert and other professors, we saw that Borrelia is moving immediately in intracellular persister forms. So it's not extracellular.
Helps to go to detect the Borrelia that's
exactly.
intracellular.
So we can reach by that, let me say, 98% of the antibodies. So
wow.
It's over 90%. This is but the test cannot tell you, is it now active infection or is it still past infection, former infection. If you are lucky, you have an IgM for persister forms, you could say, oh, there's some reactivation, because Western blot and ELISA, they don't detect the intracellular, the L forms, they are round bodies. They just detect the pleomorphic antigenity and the extracellular forms, but we need to check for intracellular forms, antibodies in chronic conditions for Lyme disease.
Perfect. And for acute conditions?
For acute conditions, we also have, I think the Western blot model works not bad in this. But we have a problem if you're using doxycycline very early, the antibody immune response can be suppressed, so you don't find antibodies afterwards, which makes it really complicated. So it makes sense to do the antibodies before you treat. That would make sense, and then to compare what's going on, because a lot of people, they have some IgG antibodies already, and they had them before the fresh infection, before this came, and we have a sentence in laboratory medicine where I'm working now for 40 years. We say one antibody test is no antibody test, so always compare antibody tests, because there's a dynamic
no comparison
process
here. They don't do another test and follow-up test. They only do one.
Makes absolutely sense. We name it a zero conversion. So if you can document IgM vanishing, if you're happy in a fresh infection to produce IgM, then you go to IgG. This is a proof that you had this infection. So very clear. But if you just do IgM, this could be persistent. This could be also a cross reaction with some viruses doing that. It's complicated, but also the best test, I would say, is the ELISpot test, the interferon gamma release assay you do in Bulls-Areshis if you don't find antibodies, because we have clearly evidence-based paperwork from CDC, which shows clearly that you can follow up with this ELISpot test fantastically if you get cured from this Bulls-Arash afterwards, because this is what you mean. We need to monitor the patient as you do it with cancer patients with a tumor marker antigens, we name that. We need to follow up. But doctors are not doing. They leave the patients alone.
How did you do?
It's horrible.
How did you do the ELISpot test? How is it done?
ELISpot is a cellular test. You need special tubes. We are doing, I think, most in the world. Internationally for patients and also for therapists, for clinic, for New Zealand and for Australia, for Canada, some American parts. So we have different options. Logistics is very important. We need fresh cells, not centrifuge, it's not allowed, not cool, not refresh, not refridge. So we need to have cellular material in special tubes. I have found out that these ACD tubes, they are named now, I think they got
They're
famous
by blood?
now. Yes, taken from a vein. Okay, for children it's a little complicated. You need some blood from them. It's not a finger test, but then you exactly can find out. This is evidence-based laboratory medicine.
This is finding the cause.
Yes, this is state of art, I would say, this direction. Not talking about a gold standard. What is a gold standard?
Are they very expensive?
No, it's not expensive. It is around, okay, what is expensive? $120 around that, 130. It's not expensive for people, but it's a good investment for following up for...
Do you need a prescription for those?
No, patients can decide by themselves, do I want this test? The health insurances are not paying so pretty well, or nothing.
How is the transportation, like, let's say from here, from America to Germany?
America or Northern America, we get some from Calgary, from Vancouver, 2-3 days. This is nice, so it's good, the quality. We optimize now to 24 hours from USA in the future, but this is fantastic test. And you have positive control, the test works, so you can double check. You have negative control, everything is good. The
So
test
they're
is
very reliable.
Yeah, reliable test. I think this is the most reliable we have now in the world, the cellular immune response. Also in Corona, we are doing a lot of these tests for immunity.
And for co-infections too?
Co-infections, yes. Also, the old-fashioned Western blot, we leave them, I think, in the future. This is a very old method from the 80s, which came up from Freddie Mercury, from HIV infections, as I mentioned, ELISA, Western blot. This is a very old-fashioned method. We are doing now more the tick-blacks, basic for the persister forms around, but is this a challenge? And the ELISpot will be the second to complement Th1 cellular immune responses with the humoral Th2 immune responses. So some patients react on Th2 system, some react on Th1, so cellular ELISpot positive, some on antibodies positive. It depends also on the Th1, Th2 balance or disbalance. If you develop that, if you have a Th2 domination, Th1 suppression, you don't find ELISpot, you have more antibodies in the end. If you have not a Th1 disbalance, you have Th1 domination, you find more T cellular immune. It depends, it's individually completely different from patient to patient.
You think this is going to change the situation of the patients? That we're guessing what is that we have and how to treat?
Many say to me or email me, now I have an explanation, you found it out, I'm happy that you're here. I said, okay, that's my job. And the ELISpot test we are doing now for nearly 20 years. So it has a longer history about their teaching books about that. Professors in Germany doing it's accredited method. Internationally, it's certified. It's quality control with some other labs or so. So there's a high quality.